Hello everyone. Today I'm going to start with another topic that is related to health policy, but we will discuss about the health initiatives which has been taken under 5-year plans. Very briefly, I will talk about what were the uh, uh, health concerns which were taken, and what were the various committees which was framed during the 5-year plans. In fact, it was in the sixth plan that the first health policy had came into the during the sixth plan, the first health policy came into existence. But before that, it is very important that we need to talk about the 5-year plans and what were the initiatives in the health sector which were included in the first 5-year plans. So, before the 1983 schemes were made under the 5-year plans which were fulfilled, and these had specific targets. So, and especially the 1950s and 1960s, it focused on managing the epidemics. Widespread national level campaigns were initiated to overcome the loss by malaria, smallpox, tuberculosis, leprosy, malaria, cholera, and others. And the approach was technocentric, wherein the health workers were trained to prevent and control disease spread. International experts and ideology influenced the missions. The necessary chemical medicines control, medicines and vaccines were dependent on international agencies. However, during the first 2-year plans, the first 5-year plans, the basic structural framework of the public healthcare delivery system remained unchanged. Urban areas continued to get over 3/4 of the medical care resources, whereas rural areas received special attentions under the community development programs. History stands in evidence to what this special attention meant, as the CTP was failing even before the second 5-year plan began. So then there was this mudaliar committee was constituted in 1962 in order to review, order to understand what were the major part of the first two plans. This committee, known as the Health Survey and Planning Committee, was set up in 1959, and this committee was set up to assess the performance in healthcare since the submission of the Bhore Committee report, also to evaluate the progress made in the first two plans, and thirdly to make recommendations for the future path of development in health services. The report of this committee had recorded that the disease control program had some substantial achievements in controlling certain virulent epidemic diseases, and this committee also found the conditions in primary health centers to be unsatisfactory. So most of the primary health centers were undersatisfied. Large number of them were being run by ANMs or public health nurses in the charge. There were certain recommendations, there were certain recommendations made by the Mudaliar Committee. By the end of the second plan, there was one primary health unit per 1,40,000 rural populations and one hospital for 32,000 rural populations. On the contrary, in the urban areas, the ratio for hospital and dwellers were 1:36,000 and 1:440 for hospital per bed per population. So clearly the health disparities were quite high and needed urgent attention. Muralidhar Committee was set up in 1959 to evaluate the progress made in the first two plans and provide recommendations. So consolidation of advances made in the first two 5-year plans were strengthening of the district hospitals with specialist services to serve as central base of regional services. Then regional organizations in each state between the headquarters organizations and the district in charge of a regional deputy or assistant directors, each to supervise 2 to 3 district medical or health officers. Then each PSCs not to serve more than 40,000 population. Then to improve the quality of healthcare provided by primary health centers, integration of medical and health services, and constitution of an all India health services on the pattern of Indian administrative services. This committee had recommended that there has to be, in regard to the control of disease specific death, improvements in life expectancy and reduction in death rate. The committee had brought forward the issues of availability and accessibility to healthcare services, and as it was quite evident from the recommendations of this committee that primary health centers were understaffed and ill-equipped. Even the health practitioners were less in number, and there was a urgent need to improve the healthcare facilities throughout. The third five-year plan, however, the third five-year plan proposed the establishment of medical colleges, research institutes, and training centers for doctors, nurses, and auxiliary staff. Through the family planning program started. Though the family planning program started in 1951, it was actively pursued in this period. Additionally, family planning initiatives was made as an independent department in the Ministry of Health. Therefore, in 1969, the fourth plan was released that continued the previous approach and goals. Under this, water supply and sanitation were given separate allocations under the sector of housing and rural regional development. But however, the third year plan launched in 1961 also discussed the problems affecting the provisions of PHCs and directed attention to the shortage of health personnel, delays in the construction of PHCs, buildings and staff quarters, and inadequate training facilities for the different categories of staff required in the rural areas. Ignoring the mudaliar committee's recommendation of consolidation of PHCs, this plan period witnessed a rapid increase in their numbers, but the condition was same as the committee had found at the end of the second plan period. In case of disease program, due to their vertical nature, there was a huge army of workers. The delivery of services continued to be done by special unipurpose health workers. Therefore, in the same geographical area, there was overlapping and duplication of work. However, then after the second, third plan, there were certain committees which had formed. That is the Chadah committee. This was come in 1963. This committee was appointed under chairmanship of Dr. MS Chadah to advise about the necessary arrangements for the maintenance phase of the National Malaria Eradication Program, and it recommended the integration of health and family planning services. This committee suggested that the vigilance activity, the NPEF, should be carried out by the basic health workers who would function as multi-purpose workers, one per 10,000 population, and would perform in addition to malaria work the duties of family planning and vital statistic data collection, and also it's focused on under the supervision of family planning health assistance. Then the Mukherjee committee in 1965, based on the recommendations of Chadah committee when implemented, were found to be impracticable. Thus, the basic health workers with the multiple functions could do justice neither to malaria work nor to family planning work. So the Mukherjee committee, headed by the then Secretary of Health, Sri Mukherjee, was appointed to review the staffing pattern and financial provisions under the family planning. Since Chadah committee failed to look into both the purpose, that is to look after the family planning, neither they could do justice to the malaria work assigned to them nor family planning. Thus, this Mukherjee committee came into existence. The recommendations of the Mukherjee committee was for separate staff for the family planning program. The family planning assistants were to undertake family planning duties only. The basic health workers were to be utilized for the purposes for other than family planning, delinking malaria activities from family planning, so that the latter would receive unavoided attention of its staff. Then the Mukherjee committee, the 1966 also suggested, 1965-1966, due to shortage of funds, it was difficult for the states to undertake multiple activities of the mass programs effectively, like family planning, smallpox, leprosy, trachoma, maintenance, that is malaria's maintenance phase, etc. were making. Thus, a committee of state health secretaries headed by the Union Health Secretary Sri Mukherjee was set to look into this problem, and as mentioned earlier, that the committee worked out the details of the basic health services at the block level and some consequential strengthening required at the higher levels of administration. Then Jangalwala Committee was established in 1967, and this committee, known as the Committee on Integration of Health Services, was set up in 64 under the chairmanship of Dr. N. Jangalwala, the then director of National Institute of Health Administration and Education. It was asked to look into various problems related to integration of health services, abolition of private practice by doctors in government services, and the service condition of doctors. The committee defined integrated health services as a service with a unified approach for all problems instead of a segmented approach for different problems, and medical care and public health programs should be put under charge of a single administrator at all levels of hierarchy. The fourth plan, which began in 1969, continued on the same line as the third plan. However, it lamented on the poor progress made in the PHC program and recognized again the need to strengthen. It pleaded also for the establishment of effective machinery for speedy construction of buildings and improvement of the performance of PHCs by providing them with staff, equipment and other facilities. The fourth plan, which began particularly in 69 with the 3-year plan holiday, continued on the same line at it, you know, but its policy decisions and plans did not reflect any social aspects. These 3 of turmoil instead, you know, in fact, the fourth plan is probably the most was the most poorly written plan document. It did not made a passing comment on the social, economic, political upheaval during the plan holiday period that was during the 1966 to 1969. These 3 years of turmoil indeed brought about significant policy changes on the economic front, and this the fourth plan it completely ignored. It lamented on the progress on the poor progress is made in the PHC program and recognized again the need to strengthen it. It pleaded for the establishment of effective machinery for speedy construction of buildings and improvement of the performance of the PHCs by providing them with staff, equipment and other facilities. For the first time, primary health centers were given a separate allocation. It was reiterated that the primary health centers base would be strengthened along with subdivisional and district hospitals, which would be referral centers for the PHCs. The importance of primary health centers was stressed to consolidate the maintenance phase of the communicable disease program. This acknowledgement was due to the fact that the entire epidemiological trend was reversed in 1966 with the spurt in incidence of malaria, which rose from 100,000 cases annually between 1963 and 65 to 1,49,102 cases. This was admitted by the Planning Commission. So it also got even more greater emphasis. The 5-year plans continue to get more or greater emphasis on with 42% of health sectors. So the plan allocation it especially highlighted the fact that population growth was a central problem, and it used phrases like crippling handicap. Very serious challenges were posed, and essential requirements were being met. It was during this period. That the water supply and even the sanitation were taken up separately for the housing regional development. The Kartar Singh Committee, came into after the fourth plan, and this committee, which was headed by the Additional Secretary of Health and was titled the Committee on Multipurpose Workers under the Health and Family Planning, was constituted to form a framework for the integration of health and medical services at peripheral and supervisory levels. The recommendation of this committee was that various categories of peripheral workers should be amalgamated into a single cadre of multipurpose workers, A&M and the basic health workers, or primary workers, female health supervisors. The work of 3 primary public workers was to be supervised by 1 health supervisor. 1 PHC should cover a population of 50,000, and it should be divided into 16 sub-centers, each to be staffed by male and a female healthcare workers. Then Srivastava Committee also came into existence in 1975, and this committee was set up as a group on medical education and support manpower to determine what steps to be taken to reorient medical education in accordance with national needs and priorities. Also to develop a curriculum for health assistants who were to function as a link between medical officers and the MPWs. Then there were certain recommendations by were made by this committee, that was creation of bands of paraprofessionals and semi-professional health workers from within the community, like school teachers, postmasters, then establishment of two cadres of health workers between the community level workers and doctors at PHCs, namely multipurpose health workers and health assistants. Then development of a referral service complex by establishing proper linkages between primary health centers and higher referral services. Then establishment of a medical and health education commission for planning and implementing the reforms needed in health and medical education on the lines of University Grants Commission, and acceptance of recommendations of the Srivastava Committee in 1977 led to the launching of the Rural Health Scheme. In the fifth plan, the government carefully acknowledged that the number of medical institutions, functionaries, beds, health facilities were still adequate in the rural areas, despite advances in terms of infant mortality rate going down, life expectancy going up, and the urban health structure had expanded also at the cost of the rural sectors. Major innovations had taken place with regard to the health policy and method of delivery of healthcare services were also enhanced, increasing the accessibility of health services to rural areas through the minimum needs program and correcting the regional imbalances. So the fifth plan was landmark as it acknowledges the widening gap between the rural and urban areas with respect to all health indicators. It also focused on accessibility of health services in the rural, as I just mentioned, through the minimum needs program. The emphasis on eradication of communicable diseases and provision of health infrastructure continued. In the middle of this plan, emergency was declared and family planning received undue attention. The provision of the safe drinking water and sanitation remained inadequate or absent in majority of the areas. Many waterborne diseases such as diarrhea, cholera, typhoid, jaundice and others affected the Indian population. Later in 1970 and 79-80, India faced with the acute drought. Hence, subsequent plan prioritized the issue of safe drinking water and sanitation. The sixth plan was influenced by the International Declaration Health for All by 2000 AD. Many radical measures were suggested by sixth and seventh plan, but the action taken was minimal. Privatization became an overarching characteristic in the 1980s and 90s. Finally, in 1983, the first national health policy was announced, and it aimed to achieve the goal of universal health care that is affordable and as per the needs of the people. Emphasis was also laid on preventive, promotive, and rehabilitative primary health care, decentralized and community participation, and it increased the role of private investors. Due to attention on selective healthcare, increased privatization, and dealing with the ground realities, the policy could not make much success stories, though. The seventh plan recommended that development of specialities and super specialities needed to be pursued with proper attention to regional distribution, and such development of specialized and training in super specialities would be encouraged in the public and the private sectors. This plan also talks of improvement and further support of the urban health services, biotechnology and medical electronics and non-communicable diseases. It also it also focused on enhanced support for population control activities continued. The special attention that AIDS, cancer and coronary heart diseases are receiving, and the current boom of the diagnostic industry and corporate hospitals were the clear indication of where the health sector priorities lie. The 8th five-year plan laid focus on the health for underprivileged but with selective healthcare approach. However, the ninth plan refers back to Bhore Committee and other significant recommendations and came up with innovative strategies such as evolving state-specific strategies, integration of medical education and health, provision of primary health centers in slum, horizontal and vertical integration of programs and improvement of disease surveillance. It also asserted the need for new health policy, and despite novel solution and ideas, the plan failed at ground level. On the eve of 10th plan, the draft of National Health Policy was announced and called for feedbacks for the public. Finally, in 2002, National Health Policy document was released with the objective of achieving acceptable standards of good health of Indian population, decentralization, equity, accessibility of health services, and provisions of affordable private health care. The role of traditional medicines was also acknowledged by this policy. During the 8th plan, resources were provided to set up the education commissions for health sciences, and a few states have even set up the university for health sciences as per the recommendations of the Bajaj Committee report. However, the Bajaj Committee report in 1986, an expert committee for health, manpower planning, production and management, was constituted in 85 under Dr. J.S. Bajaj, the then professor at AIIMS, and there were major recommendations were made by his committee, that was formulation of national medical and health education policy, formulation of national health manpower policy, establishment of an educational commission for health sciences on the lines of UGC, establishment of health sciences universities in various states and union territories, establishment of health manpower cells at center and in the states, vocationalization of education at 10 plus 2 levels as regards health related fields with appropriate incentives so that good quality paramedical personnel may be available in adequate numbers, and then carrying out a realistic health manpower survey. During the 8th plan period, a committee to review public health was also set up. It was called the Expert Committee on Public Health Systems. This committee made a thorough appraisal of public health programs and found that we were facing a resurgence of most communicable diseases, and there was need to drastically improve disease surveillance in the country. The ninth five-year plan, by contrast, provides a good review of all programs and has made an effort to strategize on achievements, etc., and learn from them in order to move forward. There are a number of innovative ideas which are taken up in the ninth plan. Reference is again being made to the Bhore Committee report. Another unique suggestion is involving state-specific strategies, because states have different scenarios and are at different levels of development and have different healthcare needs. The ninth plan also proposed to set up at district level a strong detection come response system for rapid containment of any outbreaks that may occur. On the eve of the 10th plan, the draft National Health Policy 2001 has been announced. Further, in the 11th five-year plan, the central theme with respect to healthcare sector is inclusive growth. It envisaged the provision of healthcare facilities in rural areas through National Rural Health Mission. The 12th five-year plan was prepared after the consultation of public. It called for the universal health coverage through essential health package and to assess the social determinants of health. Major thrust areas were reducing out-of-pocket expenditure, ensuring accessibility of vaccines, medicines and technology, increasing staff Ayush, that is Ayurveda, yoga and naturopathy, Unani, Siddha and homeopathy, doctors, disaster management areas, nutrition promotion, improved sanitation, and providing safe drinking water facilities. So these were the certain important aspects, certain important steps which were taken during the five-year plan, starting from the very beginning till 12th year. And within the context of the five-year plans, various subsequent policies were being made, like starting from 1983, then 2002, and 2017. And as I mentioned earlier, also that the sixth plan had crafted the way, or rather paved the way, for the first national health policy of 1983. So this was the basic I would say the brief about the health scenarios, a health aspect which was taken during the 5 year plans. So till now I have delivered, or rather I have explained the health situation in the pre-British era, during the colonial period, then what happened during the independent India, what were the measures and what were the scenario of health sectors in India during that time, and how this had paved the way to think in creating or in bringing about health policies and planning. And even I had discussed about the 5 year plans and what all these plans had, the content of 5 year plans in the context of health had been explained. So with this I end my today's lecture, and tomorrow I would be explaining about, or rather I would be focusing on the various three important health policies starting from 1983 till 2017. Thank you everyone.